Good afternoon. My name is Amy Wood. I'm the Executive Director of the Raymond A. Wood Foundation, and we are just spending a little time this afternoon giving a recap of the Hypothalamic Obesity FDA listing session we held in October. So just a little bit of some housekeeping notes on this webinar. This is a webinar, so the panelists are here, Catherine St. James and Marcy Sirota, who were presenters at the listening session. Any of your questions we'll take at the end. You can just put your questions either in the chat or the QA feature that you see in the bottom of your screen in the Zoom window. So first of all, I just want to share a little bit about the Raymond A. Wood Foundation. Our mission is to empower hypothalamic-pituitary brain tumor survivors for improved quality of life by providing access to education, technology, and evolving treatments. The foundation was founded in 2017 by my husband, Sean, and myself in honor of our son, Alex, who is now 11, diagnosed with a craniopharyngioma at 4. Alex is also a hypothalamic obesity sufferer as a result of tumor treatment. So many of us know this, but what we presented to the FDA was an overview of what is hypothalamic obesity. So our definition is excess weight gain that may occur from an injury to the hypothalamus. And some patients present, it's very much a spectrum disorder. So some patients present with hyperphagia, others have hyperphagia along with excess weight gain despite caloric restrictions. And some patients simply have the excess weight gain despite caloric restrictions without the insatiable hunger, hyperphagia. And the cause is usually by injury to the hypothalamus from a brain tumor in that area, the mostly craniopharyngioma brain tumors. It can either result from the tumor itself or treatment of the tumor, and survivors also tend to suffer from other endocrine-related disorders. One of the things I share often when I'm discussing craniopharyngioma is that it has been termed the most formidable of intracranial tumors. I think this is important to note because of its high survival rate, which is important, of course, but the long-term outcomes that these survivors face are very challenging. And we also shared just an excerpt from a report on craniopharyngioma, one that's usually referenced often. The disease or treatment-related hypothalamic damage leads to disturbed hunger, satiety, and thirst feelings, decreased energy expenditure, behavioral problems, disturbances of the circadian rhythm, temperature dysregulation, and pituitary dysfunction. Children and adults really that suffer from this tumor are at great risk for developing metabolic syndrome and comorbidities leading to premature mortality. And this report was authored by Hermann Mueller, which is a well-known craniopharyngioma researcher. So just to share a little bit about what is a patient listening session. So the FDA terms it a small and informal, non-regulatory, non-public teleconference meeting that allows participants to connect with the FDA firsthand. And it focuses on patient experiences, perspectives, and our needs related to our health or disease. It's not about a specific medical product, so not about a drug or a device. And it gives the FDA an opportunity to connect with underrepresented rare disease communities. According to the FDA, the purpose of a patient listening session is to help the agency inform medical product development, clinical trial design, patient preferences, and help shape regulatory thinking. During the session, the FDA staff will either ask questions or simply listen to better understand the patient experiences and perspectives. Only the FDA, patients, caregivers, and advocates and community representatives are participating in these sessions. So from the FDA, who attends these sessions? It's specific divisions or offices that indicated that they want to attend. And some of those divisions will designate 1 to 2 people, or some will send the whole division. And the meetings are intended to be small and focused. They estimated around 20 people in attendance. And members of the patient community are invited to listen in. So why did the Raymond A. Wood Foundation request a patient listening session? We made this request in spring of 2021 to raise awareness of the challenges of HO and the lack of treatments. We also wanted the FDA to understand how HO differs from standard obesity, which is an important distinction. And our hope was that by sharing information regarding the medical, psychological, and social implications of this disease with the FDA, we can make progress towards a standard of care and treatment for this challenging condition. So our goals that we defined with the Patient Affairs Office prior to going into this patient listening session. So we worked with the Patient Affairs Office at the FDA to really define an agenda and outline our goals. And we wanted the FDA to better understand the burden of living with this disease, the impact on families, the depth of burden on caregivers, the social implications of HO, the lack of efficacy of typical obesity interventions, the challenges doctors face when treating patients, and the need for proven treatment options. So just to understand, the format was conducted via the Zoom platform, much like this. Attendees wanted to hear the personal stories of patients first, and primarily and secondarily the caregivers. There was a question and answer session at the end of the presentations. And this was a closed meeting, so it was not recorded. So that's much why we are presenting some information today. And Raymond A Foundation did develop a post-event summary that is currently on the FDA website. Okay. So who from the FDA attended? So these are the divisions that attended from the FDA, the Office of Commissioner and 5 offices within that division, the Center for Biologics Evaluation and Research, 2 offices within that division, the Center for Devices and Radiological Health, 3 offices within that division, and the Center for Drug Evaluation and Research, which had 4 offices. There were about 30 people from the FDA in attendance, and you can see the full list of offices in the patient listening session summary, which is posted on the FDA's website. So what did we share in our patient listening session? We focused primarily on patient stories, the current research, observations on response to lifestyle interventions. We talked very much about the quality of life of HO patients, some treatments that have been tried and the response. We talked about family struggles. Survivors shared their personal struggles growing up with the condition. And we also shared a lot of information about HO in comparison with standard obesity. And we'll share a little bit more about that in a few slides. Our presenters at this session, were, aside from myself, were Dr. Shana McCormack, a neuroendocrinologist at Children's Hospital of Philadelphia, Catherine St. James, who is a survivor growing up with HO. We had Eugenie Shu and her son, Alex Riley, caregiver and survivor. Jeanette Rials, who was an avid exerciser and marathon runner prior to being diagnosed with a craniopharyngioma and then suffering HO. Marcy Sirota, who's with us today, registered dietitian, nutritionist, and caregiver. Marcy treats many patients with HO. And Christine Selko, who is a caregiver to AJ, young adult living with hypothalamic obesity. And the topics that we tackled included just an overview and background, much like I shared with you earlier, hypothalamic obesity diagnosis and the current state of treatment, living with HO from a survivor's perspective, the caregiver burden, how exercise affects hypothalamic obesity. It's also its response to dietary interventions and the long-term impact on family. So we're going to talk a little more in depth about HO versus standard obesity and those lifestyle interventions. So I'm going to turn it over to Marcy to go through these slides with you. Marcy, you have to unmute, I think.
Hello. So yeah, I talked a little bit about HO and diet and explained that hypothalamic obesity does not respond to a traditional low-calorie diet with exercise, and how frustrating that is for patients and for caregivers, and that they may respond in some but not all cases to a very low carbohydrate, no sugar, no processed food diet, which is often very difficult to follow and very expensive. So it makes it prohibitive for people that just don't have extra income to spend on fresh, non-processed foods. And then how even a little sugar, which is sort of ubiquitous in all the foods that we buy, seem to make the hyperphagia uncontrollable. And that diet and exercise alone usually don't move the scale very much. And patients quickly become frustrated and defeated, and how most physicians, in our experience, are ill-equipped to help these patients as there are no effective FDA-approved pharmacologic treatment options, so no medications that can help this condition that are approved by the FDA. Next slide. So as Amy said, HO is a spectrum. So that means there are mild cases, moderate, all the way up to severe. And the response to diet and exercise are going to fall somewhere along that spectrum as well. So those with severe HO, even with that strict proper diet that I was talking about and exercise, someone with severe HO, their best hope is to be able to only slow the weight gain, but it's very, very difficult, if not impossible, for them to lose weight without some sort of additional medication support. There are those with moderate HO where their HO is very stubborn to weight loss. They gain weight super easily. They pile on, 100 pounds after being diced, after their HO sets in. But with strict diet and exercise, appropriate exercise that builds muscle mass, they are able to move the scale maybe up to 40 pounds. And then there are those with mild HO who will respond to a strict proper diet and exercise, but that doesn't mean they're necessarily going to be able to reach their weight goals or maintain what is considered by the medical community to be a healthy weight. Next slide. So this is a slide I made just sort of trying to explain to the FDA how, although, hypothalamic obesity, they seem to think that they didn't understand what the difference was between HO and sort of typical obesity. And I made this chart to demonstrate that HO actually has a lot more in common with starvation than it does with obesity, other than the weight gain factor. So you can see all of the green checks are the things that these three conditions have in common. And then the red X's are going to be the ones that they don't have in common. So you can see how many green checks are both in the starvation category and the hypothalamic obesity category. They both share low metabolism. In both cases, you will have people eating out of the trash can, sometimes eating things like raw chicken or food that's been, left out for days. There's the constant hunger signal that goes on, usually with both starvation and hypothalamic obesity, although they're caused by different reasons. And then in cases of starvation and HO, you will have people that will steal and sneak food. And then the only things that really standard obesity and starvation have in common, very little actually. I'm sorry, what I meant to say was what starvation and HO do not have in common are, with starvation, you don't have high insulin levels, and with HO you do. And then with starvation, you don't have the weight gain and fat storage, and with HO you do, which also is going to be what HO has in common with standard obesity, the high insulin levels and the weight gain and storage. Next slide. So HO versus standard obesity. What is the physiological response to attempts at weight loss with standard HO? Just to sort of summarize, with standard obesity, you have this increased insulin sensitivity, which happens as a result of weight loss and exercise. You start to see decreased insulin levels, which is what you want to see because insulin is an anabolic hormone that causes weight gain. You see carbohydrate and fat stores starting to be broken down into fuel, and you see weight loss. So that's something that happens with typical obesity. Whereas with HO, insulin levels remain elevated while at rest, despite weight loss and exercise. And so they remain in this anabolic state where the body remains very stubborn to weight loss. And despite diet and exercise, fat stores seem to be preserved in hypothalamic obesity. Next slide. So with exercise and HO, why does HO not respond to exercise? I suspect it has to do with disturbance to circadian rhythm and excessive daytime sleepiness. So, these patients are waking up in the middle of the night. They have a very hard time falling back asleep, and therefore they're very sleepy during the day. They lack energy. Often their hormones aren't replaced aggressively enough. And then they're also very tired. So that gets in the way of them being able to exercise. And then they have a lower baseline metabolism. So if somebody has a very low metabolism, exercise is going to be less effective. And, we're unsure exactly why HO does not respond to exercise the way regular obesity does, but it is likely a combination of the low metabolism, high insulin levels, which make the body resistant to weight loss. And just as an example, we have a gentleman here on the right side, Prince, who was a tri-sport athlete in high school and had unexplained obesity, which did turn out to be diagnosed as hypothalamic obesity. And he was very, very active, but still unable to get down to a body weight that would have reflected the amount of exercise he was doing. Next slide. And then I just gave a little bit of information about my personal experience as a caregiver living with HO. My son had it from the age of 3 all the way up till much more recently. And it was a living hell. I mean, the children can't be left unsupervised with food. We had to lock up food at all times. Just to avoid him getting to a place where, he was going into liver failure, developing type 2 diabetes, sleep apnea, high blood pressure. Nobody wants to live that way. Nobody wants to lock up the food from their children. We felt very socially isolated because we just couldn't go to parties and afford to be exposed to all the unlimited food and high sugar and processed foods that are always served at parties. And there were usually temper tantrums involved, when we would try to cut off the food. So it ended up in us sort of, the only way to control his weight was to socially isolate ourselves. And then children and teens often become aggressive to their caretakers over food. So that becomes a real issue after a while.
Thank you, Marcy, for sharing that. And then we also, after going through that information, we also shared with the FDA the current medications that have been used off-label to attempt to treat the symptoms of HO, as you can see in this list. But to date, very few of them have fully been researched to show efficacy and seem to sort of rely on the clinicians and the caregivers to attempt to try to anecdotally see how these affect the HO sufferer, as well as the survivor if they're old enough. Oxytocin was recently in a clinical trial that wrapped up, so we're waiting to hear the results from that. Also, the GLP-1 receptor agonists have been studied to some degree, but I think all do require further research. So one of the things that we just wanted to, or we sort of observed the reactions from the FDA. So once we concluded our presentation and were opened up to questions and answers, some of the members of the FDA expressed that they had never heard of this condition. There was some questions around craniopharyngioma and its prevalence, and ultimately the prevalence of HO. And then there was questions about whether there was a medical device in development for HO, which we are not aware of at this time, but also expressed general compassion by what is faced by survivors with this condition. We sort of felt a little bit of a stunned silence, I think, in the beginning of the Q&A session. I think that with the fact that the condition is largely maybe unheard of at that point, there was a lot of just sort of processing what we had presented. So I'm going to take a moment just to share so Marcy and Catherine can unmute and just take a moment to just kind of get some discussion about the presenter experiences. I wanted to start with Catherine. So Catherine presented her story of growing up with HO. And Catherine, can you share a little bit about that story with us?
Yes. Let me see if I can actually start my video as well. So for me, I was diagnosed at 14 years old, and I had been an athlete prior to my diagnosis, so I had no indication of hypothalamic obesity beforehand. And then after my surgery, I didn't really gain weight initially. I would say for the first couple of years, it was stable. And then every 3 or 4 years, because it's been 15 years now, I would just gain, it seemed like overnight, 20 pounds. So, in total, I gained almost 80 pounds from the time of diagnosis to about 15 years later, where I'm at now. And as Marcy said, there's different degrees of hypothalamic obesity and hyperphagia, and I was actually a mild case. Yet I still gained close to 80 pounds, and I was able to restrict what I was eating. I was a teenager when I was diagnosed and as a young adult, so I knew about portions and I would count calories, and I just wasn't really able to drop weight. And it was socially isolating too, because you would go out to eat and people would be like, why aren't you eating? And you didn't want to eat because you didn't want people to comment. And then if you were eating, was it too much? So it was definitely very socially isolating, as I said, and just just not a fun experience to not be doing anything differently than you were prior to surgery, yet to be packing on these pounds. And again, I was not one to seek food out of the garbage. I didn't really experience severe hunger pains either. I would just get hungry once or twice a day, yet the weight still came on. So I recently this year, I actually went to nutritionists and I did start a low carb diet, and I was able to lose 60 pounds. And actually losing the weight has made me more passionate about finding medications that treat HO, because I didn't work this hard to gain it back. So I'm very interested and curious about all the options that are going to be out there, because the one thing that has been mentioned is that these diets, low carb diets and restrictive diets, are very expensive as well, and they limit your options. So I'm fortunate that I was able to lose weight, but now I'm nervous because I want to keep it off. And so that was really my motivation for participating, to show the mild range and how even a mild case is really not so mild at all.
Oh, I'm talking and I'm on mute. Excuse me. Thank you, Catherine. I was just saying that I think this time of year too, it really challenges us in the HO community, because whether we're caring for our children, we're faced at every angle with anything that's going to break that low carb, low sugar diet if we're getting together with family. So the alternative is social isolation, which is not ideal. And so yeah, it's definitely hard to maintain that eating structure. Catherine, what did you feel? What were your impressions given presentation? Just what were your impressions of presenting to the FDA? If you want to share any thoughts on that.
I definitely was more intimidated than I needed to be. They were definitely just normal people. And it definitely, as Amy said, it showed with their emotional reactions in the Q&A part. I was surprised that they did not, they really had a few of the FDA workers, they really struggle to understand the difference between obesity and hypothalamic obesity. And they, even in their questions, were not quite understanding the difference. And so, but they were curious, and they wanted to learn. And it just goes to show you how intricate this topic really is. But I know that I was moved by the other panelists speaking, and I believe they were as well.
Mhm. Yeah. Marcy, can you share any insights on your impressions of being in this, participating in the patient listening?
Yeah. Do I need to? Okay, I'm
You're
unmuted.
good.
Yeah, it was very emotional. It was interesting. One of the panelists was talking about her experience with the hyperphagia piece, and my son suffered from hyperphagia, and so he was very young. It started when he was 3 years old, and so just to hear her articulate, how intense and unrelenting the hunger was, and I could see it as an observer in his drive to eat and to get to food. But it's another thing to hear it firsthand from somebody who is experiencing it. So when I went into my talk, I was basically in tears, having just kind of been brought back to that place where life was just so difficult, and it seemed like there was no hope. And just day-to-day life was just, very, very hard. But I agree with Catherine. I mean, it did seem like they were very interested and very moved. And I think that we definitely got through to them. I think our mission was accomplished. I think they walked away really understanding that this is a very different condition than typical or standard obesity, and that they, do need to divert some resources or, approve studies, approve drugs that are going to give these patients some relief.
Mhm. Yeah, I think it was very moving to hear that account from an adult who had led her life, very healthy, very exercise focused, was diagnosed with a craniopharyngioma, knew ahead of time of what could possibly happen, but thought she had prepared for it, if that was the outcome, and then unfortunately was faced with the extreme hyperphagia. And hearing from her what that felt like, I think all of us, even though we're all in it, truly just it broke our hearts again, because we could hear it from an adult perspective. Our kids aren't always able to articulate what that really feels like. So yeah, I think that was where we really got into the kind of that stunned silence, where they were like, aha, wait a minute, this is a much deeper issue. Is there anything either of you would like to add before we move on?
I would just like to add that, I feel really hopeful. I think that this was such an important thing for the Raymond A Foundation to do. And I'm so glad that y'all exist, because I would have never known to do this, because without FDA really knowing and understanding about hypothalamic obesity, there's not going to be any new treatments developed. They're not going to be as motivated to approve them, even if there are studies by clinicians who understand the condition. So I do feel very hopeful and positive that this is going to open the door to hopefully a lot of new treatment options for this condition, which will improve quality of life. So just hang in there. We're moving in the right direction. And if you are able to join the Raymond A Foundation as a member and, help us in this battle to kind of bring awareness and fund more research, the better our lives will be as patients and caregivers.
Thank you, Marcy. Okay. And just a reminder, as we're concluding this presentation, if you have any questions, please feel free to put them in the chat or drop them in the QA box for us to answer at the end. So it has been a more exciting year for hypothalamic obesity, as we do have, to our knowledge, 2 current clinical trials. One is the open label study of setmelanotide in hypothalamic obesity, sponsored by Rhythm Pharmaceuticals, and recently opened phase 2b study of Testament with open label extension in subjects with hypothalamic obesity, sponsored by Sanyona. And all of that information can be found on clinicaltrials.gov. So what are the next steps for Raymond A. Wood Foundation? So as I said, we drafted and shared a summary of the patient listening session that currently lives on the FDA's website. If you Google FDA patient listening session summary, it'll pop right up and it's on that page under hypothalamic obesity. We will continue to raise awareness around the need for research and treatment for this condition, others that are challenging our brain tumor survivors. We also will continue to work to inform treating doctors on management of this condition. We would like to get to a standard of care. Communicate and collaborate, continue to communicate and collaborate with pharmaceutical companies while keeping the community informed of clinical trials and treatment innovations on the horizon. We will continue to support research in HO and other conditions from hypothalamic-pituitary tumors, and continue to provide education and support. The Raymond A. Wood Foundation was recently awarded a grant from the Chan Zuckerberg Initiative to be part of their Rare as One Cycle 2 cohort. So we will have the opportunity to build the foundation's capacities to support a research network where we hope to bring clinicians, researchers, and the patient community together to solve more of the problems around treatment and outcomes of craniopharyngioma and other tumors similar to craniopharyngioma, and to develop the standard of care, as well as working to better support patients with these secondary conditions from these tumors. We also have a hypothalamic obesity page on our website that we are constantly updating with the new information. We have some we also have an awareness video that we share with the patient perspective and caregiver perspective on hypothalamic obesity. And you can find that on our YouTube channel. So please take a look and subscribe. We're putting new content out about HO and the other conditions on a regular basis. And then how you can help. So one of the ways that you can help support our work is to respond to surveys that we put out so that we can help gather data to inform research, learn about and participate in clinical trials, share your story. And after the holidays, we'll be asking people who are willing to share their personal stories about living with this condition and others related to these tumors. And as Marcy had said, we welcome you to become a member of the Raymond A. Wood Foundation and join us in our advocacy efforts. The more we join together, the more we can build momentum as a team to come to solutions and to improve the outcomes for ourselves if we're survivors or our loved ones. So right now, I don't see any questions in the chat or the QA. So I will just pause for a minute to see if anyone has any questions. I also just shared some quotes, and they shared this with the FDA from families and survivors with hypothalamic obesity. And just thank you, Janet. Dietrich, for your comment, and Mike Raw, thank you. We're happy to do this work. It's unfortunate that we have to. I think all of us feel that way, but we're passionate to find a better way, for sure. So Marcy, Catherine, if you have any final thoughts.
I don't think so.
I'm gonna put you on the spot. Well, my hope is to do this in 30 minutes, so we're awfully close. If anyone has any questions offline, you're welcome to email me at amyw@rawoodfoundation.org. We will be keeping the channels of communication with the FDA Patient Affairs Office open, so we will continue to have a dialogue, and we'll certainly request other listening sessions in the future for other rare conditions that result from these tumors. So thank you all very much for joining us today. We absolutely appreciate you taking the time And again, for more information, you can also visit rawoodfoundation.org. Thank you, Marcy and Catherine, for being with me today. And happy holidays to everyone.